Good afternoon, everybody. And as David said, right, I'm saying as like David, good afternoon to everybody, right? So, and if you sometime if you gotta miss somebody, then I'm going to feel that good afternoon with myself. So good afternoon, and let's begin with before beginning with my talk. I'll just to thank the organizing committee for allowing me this opportunity for the presentation of my research work. And actually, this is the research that I have done during my PhD in the Thailand, and all the samples that has been done, basically with the samples that has been done in the Nepal, and that's why today. I'll just focusing on the molecular epidemiology study that has been done in the Nepal. So let's get started with that. So these are the trends of the global HIV infection that has been going on since 1990. The spike has been going on, right? In the mid and in the early 2000, it has been spiked up in the higher later on. But we can see that now it has been declining, right? Probably by the day today we'll be getting the new reports, and we hope that it's going better down, right? And we hope that we will be seeing that someday will come that there will be no HIV. Let's hope for that one in this day, right? So, but here we know that this is the way the global trend of the HIV has been reducing since 2010, right? So, as I'm talking about the epidemiology, I just want to put the light on what are the global scenarios of the prevalence of the HIV, and here we can see that the prevalence is that mostly we know that it's a 0.8%, right? So. Here this is the way, and here this is the Nepal. This is a small country we lie between India and the China, and here the study has been done in this part of the world. Okay. So this is my country. It's a beautiful country. So if you know that, so we are saying that we are the countries of the temples, right? So you can see that there was saying that there are more temples than the more people lying over in the countries, all right? And this is another one. It's a iconic tower over there, but it used to be, right? And this is another one. That's we say with the Tower of the Peace. That's the Lord Buddha was born in Nepal, and he's the sign of the peace. So this is the way how it reflects the sign of the peace. But unfortunately, I don't know if you have gone through the news or not. So there was a huge earthquake, right? So in the April back. So because of those earthquake in April and the May, so we had to. So these were the calamities, right? And you can see that those iconic tower has been demolished, right? This is the condition, and even the sign of peace that has been disturbed. That's why we are getting so many wars. I don't know. That might be the reason. So it's showing that the peace has been disturbed, and the temples that we see earlier. It's lots of debris, right? And that was that. Usually, it was unfortunate for us to happen to in our country, but still, we lost the life, we lost our towers, and we lost all these natural structures. But still, we have hope, and we have been standing. We have hope for the smiling, and we have not lost our smiles, and we have not lost our hope, right? So on this day, I would just like to dedicate all these smiles to the people who have been living with PLWHA, right? And all wonderful people like you who have been working day and night to eradicate the infection. Let's hope someday we can say that HIV will be there like a history, right? So all this dedication to all the people, okay? So thank you. So let's come back to the talk. So. We already mentioned that this is a small country. It's Nepal, so we have the population of like around 30 million people, and we have in between the sandwich between the two different countries, India and China. So recent data I went to the UNAIDS that we had the global the prevalence rate of the Nepalese people is at 0.3%. So that will account around 65,000 people that have been living with HIV. So. Nepal comes under the Asian region, so it's a SAARC country, and this is the normal prevalence rate of the different subtype of the CRF that can be found in Nepal in the ASEAN countries, and the C is the most dominant part of the subtype that is prevalent in Nepal. So similarly, these are the more picture that you can see that mostly, along with the India, we are the one that mostly the subtype C is quite common over there. the subtype that is prevalent in Nepal. And this is the way, so this is the country map, and here you can see that the central region of Nepal. So we have to, usually our country is divided into 5 different parts, depending on the development region. And the study has been done mostly in the central part of the region. This is the way where this study has taken place. So this is the normal epidemic snapshot of the HIV that's prevalent in Nepal. That's around 65,000 people that have been living with HIV/AIDS. And it's around like 7,500 people it's getting the new infection every day. But the recent data that has been saying that it has been decreasing and diminishingly from since the last couple of years. And usually the people, they are on ARTs around 4,000 people, but mostly the quite confusing is that mostly there are some rural countries, rural part of the world, the countries, they have been quite prone to go to the immigrant labor in the India, and they are very prone to get the infection. So, but they are not exposed, and they didn't have a chance to come to the doctors and to the hospital. So I don't know. So we don't know that this is actual data or not, right? So there must be much more hiring people who has been living with the HIV/AIDS, but this is only the documented data that usually come to the hospital, and that those people who had a good access to the hospital, right? So the objective of the study was to, we know that there has been subtype has been prevalent in the Nepal, but that's usually, if you coordinate with the HIV in the Asia or India, that's what that was see. But we want to go for that if there is any subtype recombinant form, or is there any mutation in the different CRF was formed. So we conduct this study. And another one is to find out do the HIV that is prevalent in HIV in the Nepal has any correlation with the genetic subtypes in India or in the China. So for that, we did the whole level genomic study, right? So till the date, before my study was done, no study has been done for the full genome analysis. There are only some limited data that usually do the gene analysis for the GAG or many few journals or literature for the pole genes. So to find out those, to get the clear of the confusion, so we plan to do the whole genome analysis, including GAG, pole, and envelope, right? So this was the first study that we conducted in Nepal to find out what is the actual condition of the prevalence of subtypes in Nepal, right? So for the material methods, actually, we did the whole genome analysis for the 136 samples, but I'm just presenting only 10 samples for the whole genome sequence analysis because we had our other lots of work going on, and so I'll not be telling much more. So here I'll just be going on the 10 samples that has been whole genome analysis from the central part of the region. You can see over here, and the capital city is Kathmandu. It comes under the central region of the Nepal, and usually the sample were collected around July to September in 2011. So all the samples. And these are some data that you can see that here the sample IDs code were given for them, and you can notice that all different risk group has been involved, right? So we don't want to miss any risk group. All different 4 risk groups, heterosexual group, IDUs, MTCTs, as well as MSMs, they were included in our study, and even you can see over in the top end, in the last end, that you can see that the AIT status. So we want to be generalize everything, right? We want to include all the risk groups, and we want to include whether there is any changes in the ART or any status of the ART or the people who has not been having non-ART. So these are and during this study, these were the viral loads. So when we go for the sequencing or for the genome analysis, these were the condition for the different viral loads. So these are all the other samples that usually taken. And this is one of the hospitals that comes under the central region of Nepal. We say the Bharatpur Hospital, and this is where we get mostly the samples from there. And this is the way how the people has been accommodated, or we collected the blood samples from them. And this is the procedure how we get it. And once the blood were collected, so they were airlifted to the Bangkok, the Siraj Mahidol University, or the Siraj Hospital, where I did my PhD. So with the help of World Courier and only all the samples, they have been transported with the -20 degrees, so that our virus will be viable for us and it will be easy to study. So all those samples, they have been airlifted to the Bangkok. So these were the ethical issues that we covered, so that we get all the IRBs and from the institutional factors as well as from the ethical clearance from the Nepal Health Research Councils, so that we can go for the custom clearance. And these were the difference. And during collecting the samples, we also gone through all kind of sign informed consent. So we tell them what the study was and what is the benefit for them. So these were all the ethical issues were addressed. And these are I'm just presenting only 10 samples of the full genome analysis, and this is the general baseline characteristics of the samples that has been done over here. You can see that the ratio of the male is quite a little bit higher compared to the female, and both of the group were included, either EIT experience as well as the EIT people were, and even the different risk groups people were also included over here in these studies, so that it can address all different risk factors, and all the age groups were there. So once we airlifted the samples, then the first and foremost thing we did was the viral load was done. So viral load was done by the M2000 real-time PCR. So once we did the viral load, so that it will be easy for us to screen out which samples should be chosen for the genome analysis, right? So that we will be getting the good sequence, and so that it will be easy for us for the interpretation. So on this basis, we use the viral load. And actually, in Nepal, the condition is that we have only one place that's a reference lab from the government, and since 2011 that we had started the viral load. So it's not common everywhere, and that was the reason. That's why I have to airlift the samples for the viral load over here in the Bangkok. So here, I'm just putting this slide so that during my study that we did all this, the genome, all the 9.2 kilobase per genome was involved for the sequence analysis. And these were the data analysis. How they were done was usually once the samples were done with the viral load with the M2000 real-time PCR, and then later on we went for the phylogenetic analysis. We're using the genetic analyzer with the applied bioscience, and these were the difference, like the virus sequence for using the pol gene, and all the GAG and envelope genes were amplified using the nested PCR, and those nested PCR, the amplified gene were taken for the phylogenetic analysis with the help of sequencing machine, right? And ultimately, we did the phylogenetic tree analysis to find out what is the actual scenario of the subtype distribution in the Nepal, and whether they have any similarities with the neighboring countries, and what might be the reason for causing the much more infection in the Nepal. So this is the way this is a software that we use to check the gene mutation over there, and does any gene mutation has a role in the drug resistance being developed in the Nepal, and even we were also able to find out the signature pattern analysis that were quite common in different risk group of the people. Either it should be MSM, or it should be IDU, or MTCT, or HSR. So let's come to the result. That here you can see that mostly here you can see that. So almost all the samples, they had a tight cluster with the subtype C distribution here. Mostly the MIDU, that's the subtype of the subtype C that is usually prevalent in India. And here you can, and it's much more the Asian part of the country, and as well as this is the part in the Myanmar. So here we can see that from that here we can see that mostly those samples that has been a genome analysis has been done to see that the phylogenetic tree can be seen that they have quite similarities with the Asian region that has been quite prevalent in the region. That's much more in the subtype C. And it's believed that the HIV was first known in Nepal was in 1988, and it has been believed that, although we didn't have a documented data, but it has been said that it comes from the female, the migrant labor who has been working in India, in the southern part of India, and she was once she came back to the Nepal, and she was the mode of the transmission, how it started. And to prove that one, this does have a role. That from here we can see that the prevalent of the HIV that they usually had a cluster with the subtype C that's quite prevalent in India, right? So after we did the phylogenetic tree analysis, so with the sequencing with the whole genome, so this is the way that how we went with the software JPHM, how we can see that. So we involved all the genes, the GAG, pol, and envelope genes were involved. So the highlighted part, you can see that the color with the brown is subtype C, right? So when we did the phylogenetic tree analysis, and when we put them in the JPHM, we can find out that out of the 10 samples, they interpret the subtype C. So as mentioned over here with the orange color, and the only one sample, we can see that there is a sample number 079, and you can see that there has been intermixing with the subtype C and D. That's mostly in the pol region, right? So it means that there is some kind of the or before our study, it was known that the subtype C is only prevalent to the Nepal. But with the help of the study, now we came to know that there is there are the other CRFs, right? So recombinant form is prevalent in Nepal, and still we are getting some CRF 07ABC that's quite prevalent. That's what the common in the China also. We are under process. Probably there might be any other mutation gene has been going through the Nepal also. So from now on, now we can say that there is a subtype C, not only the subtype C, but there is any more CRF is being prevalent in Nepal, right? So this was the only, so once we know that there has been, so here we can see that once we know that there has been some recombinant in the pole gene, so we went to find out what was the genome actually, the level of the amino acids was there. So later on, this was the data that you can see that. So here we can see that. So from the nucleus of from the genome base pair to 2700, it's like C, or from the 2700 to 3500, that's the part that's the subtype D. So this is the intermixing between subtype C and D. Okay. So this is, and then we want to make sure that whether that CRF that's is sure or not. So that to make much more clear, we went for the recombinant breakpoint analysis, and we did the posterior probability test. And with the posterior probability test, here we can see that yes, it's true that we can see that both C and D is the recombination form that's quite prevalent in Nepal. And there's the one sample. Depending upon the different base pair over there, you can say that there is a recombination has been prevalent. So then after we found that there has been some prevalent recombinance form in the pole gene, right? We know that the pole gene is responsible for the drug resistance and the mutation. So then we went inside further. So is there any mutation in the amino acids so that they are doing any resistance? So then we selected all the samples, and we found that difference from the disease group. And here you can see that there is some kind of the mutation in the base pair 103 that you can see that glycine has been with the arginine, or some valine has been replaced with the aspartate. So these are the amino acids. There has been some kind of mutation. So ultimately, because of this mutation, they might develop this kind of the drug resistance that they has been using over here. So from this point, now we came to conclusion that yes, there has been prevalent, there has been the recombinant form, and we are very prone to get the drug resistance in the near future, depending upon the gene mutation. So then again, we want to further go for that. Is there any amino acid polymorphism here with a different risk group? Suppose here is the NP008. That's usually with the group that has been with the HSR, and NP015. That's the group of the NPCT. So we want to find out, is there, depending upon the different risk group, does there have any changes in the amino acids? And we found that yes, there has been some kind of changes. With the colored over here, we can see that there is some kind of minor changes. The black with the red, there is in the amino acids in the position number 33. Usually there should be the lysine. There is the glycine, right? This is the way we found that there is some kind of signature changes in the pattern has been changed depending on a different risk group, right? So then this is the way how we did any signature sequence pattern was done, like the NP003, the sample from the heterosexual group, and NP131 is the sample from the MSM. So we came to come that depending on different base pairs, right? There has been some changes in the amino acids. In place of D, there has been A, or in I, or this is the signature pattern that has been found in the prevalent in Nepal. So now as we in our group, there are 4 different groups, so we just want to compare with HSR with the MSM and HSR with the IDU, and we still find that there has been some kind of changes in the amino acid pattern depending upon the different base pair. And we also find that mostly all the N9 positions, they had like a GQ pattern that we usually find in the V3 loop of the envelope region. So this was the region that we can find it, and mostly that had like the CCR5 receptors were quite prevalent compared to because of the pattern of the GPGQ over there. So ultimately, let's come part of the discussion that we should so as this study, we involved all the different risk group here, right? And we came to conclusion that there has been distinct cluster has been known to the subtype C. So all those clusters, they have very close relation with the subtype that is found in neighboring countries. So it has. So whatever we have been saying earlier is that the infection had been originated from the single ancestral site. That must be probably from the woman who is working in the southern part of India, and she was the one reason, might be because of our genomic analysis, right? And other than that, before our study, it was said that only the subtype C was prevalent, but from our study now we're proving that there is a recombinant form is quite prevalent in Nepal, and that's another issues that we have to be challenged in the future, and it's going to be huge challenge because it will be going for the drug resistance also, and we don't know, there might be some more mutations, so we have to go for that one, although our study has some kind of limitation. So because we are involving only in the central part of the region. So now what we are doing is that we want to involve whole different part of the country, so through the whole of the region, so that we can say that, so that there won't be the day that there is a drug resistance will be developing in the country. So our next project is that all the different 5 regions we are planning to do the whole genome analysis and to find out what is the actual scenario of the recombinant, or what is the actual scenario of drug resistance, or what are the things that we can get prepared for in the future to prevent the drug resistance in the normal scenario. So in the conclusion, it's a near full length genome subtype. It's a first study in Nepal regarding the whole genome analysis, and here. This might be another critical factors, mostly in the monitoring the HIV pandemics, and that can be used for the vaccine design in the future, so that we can correlate this data for the vaccine design and efficacy, as well as the HIV treatment outcome, depending upon the resistance usually they develop. And so that's why because of that limitation, we are planning to do for the molecular surveillance of the countrywide surveillance, so that we can come to a point. So what is the drug resistance pattern, or what is the subtype prevalent in Nepal? So I would like to wrap up my talk over here, and I'll just like to give my thanks to my major advisor, and so they are my co-advisors, and usually they are the laboratory groups that I use during my PhD in the Bangkok, to NHRBC and the Department of Microbiology in Faculty of Medicine, Shiraz Hospital, and the participating patients who has given the consent as well as the blood, so that with the help of them, this study has it's come to our study, and the staff of the Bharat Hospital from where the sample has been taken. And currently, I'm a faculty in the University Hospital in Kathmandu, Nepal, and I'll also like to acknowledge my department also. So all this financial support for this project has been given by the Shiraz Hospital for the thesis scholarship, and thanks to everybody. And these are some references that we usually go for this study. And another thing is that although we lost more life, or another thing is that thank you for all, and we are the country of the Mount Everest also, right? So everybody, you're welcome. If you got a time over there, you can go for a trip like the hike. Thank you all.